You are ready? Yeah. So, good afternoon. Thank you for being with us in a session that I think it's too early, not in the day, but too early in the forum. I'm very happy because I'm moderating, but I'm actually directly involved with a project that we all have been very passionate about, and which is a European Union project, but it has a lot of representation, let us say, from countries that have not been very, very active in this type of implementation research. And very quickly, to go through our speakers, I have with us Tony Dedeo, who was in our advisory board, formerly of WHO, but also a very well-known senior advisor for primary care issues. And we have with us, we're very happy to have with us, it's always difficult to involve policymakers, so very happy to have with us Deputy Regional Minister from Andalusia, from Spain. So Professor Dr. Maria Luisa del Moral. Very happy to have with us from Agenas, from the Italian government, Elettra Carini, who's a young professional that's expanding from public health to also management. And last but certainly not least, we have with us Maximilian Schwarz from GERG, so from your very own Austria. And online, we have, I'm going through the introductions now because it's quite difficult. We have Lukianos Gadzoulis, misspelled, who is a senior policy advisor in a state of health unit of the Director General for Health, and who has been with this joint action project from the very inception. And last but certainly not least, Professor Christos Lionis, who is Professor Emeritus and is most cited primary care researcher and general practitioner, and will be with us remotely. And without further ado, I would like to pass virtually to Dr. Gadzoulis to give us a little bit of background on how this joint action was created, how it came about, and how it was funded. Thank you.
Thank you, Elena, and thank you for the opportunity to be part of this session. Good afternoon, ladies and gentlemen. I think we all know, we acknowledge that strengthening primary care is a central element in health system reforms. It is on the policy agenda of health systems in many member states in the EU, and it is part of the analysis of national health systems every year under the European semester. Now, each year under the European semester, several member states receive country-specific recommendations to strengthen, to improve the health system. And some of these recommendations concern primary care. And this has been the case even before the COVID-19 pandemic and up until now. For instance, this year in 2025, it was Lithuania and Slovakia which received country-specific recommendations to strengthen the primary care. Clearly, we see that in several countries and regions, primary care has not reached its full potential. And this is a matter of policy attention. And at the same time, we also see trends how primary care is evolving with new approaches. And the direction of travel is mainly towards person-centered and multidisciplinary care approaches. And this entails several aspects, such as establishing primary care centers with multidisciplinary care teams, integrating health promotion and disease prevention in primary care, integrating digital tools to support patient management at home, and also developing personalized care plans for patients with complex conditions to address what matters most to these patients. So evidently, in addition to the policy guidance which the European semester can offer, we also have noticed, we have seen the need to offer more practical support to member states. And this can include funding, but also support to build knowledge on how to reform the primary care systems. To this end, we launched the Joint Action CIRCE as an instrument to support health authorities understand how innovative approaches in primary care work, how they can be designed, and how they can be tailored to the specific regional or national context. So we expect Joint Action CIRCE to be very influential in this regard, specifically in terms of demonstrating that proven innovative practices can be transferred and they can be adapted to new locations by increasing the confidence of policymakers and health professionals in new primary care models, and by reinforcing the capacity of health authorities to successfully design and implement reforms in primary care at large scale. Thank you.
Thank you very much, Lukianos. Also to thank you for providing a little bit of insight and mentioning the semester, and we encourage everybody to look at recommendations there. Sometimes policy is too far away from the field, and indeed from research.
You can share the PowerPoint.
Not yet. First, we need to go. I think you need to be muted. And first, we need to go to Anna, who is the coordinator of the action. And Marco is very kindly supporting us as Janka Steiner and Eurega. And I think you have the microphone. So if Anna, I think you will have to, yes. So Anna, it would be useful to know a little bit on how this came about and for the coordination, and of course, the initiative for Spain.
Yes, thank you. Thank you very much, Elena. I'm delighted to be here and to have so many friends wanting to know more about CIRCE-JA in Action. That is a collective effort responding to the call by the EU, in which 48 entities are collaborating from 14 member states to effectively transfer 6 innovative best practices in primary care to other territories, taking into account the differences in cultural, social, and structure and the healthcare systems. So it's a big challenge because it's not so easy to move an element from one territory to another one that is completely different. And generating knowledge. I think we will listen to the methodology that we have developed. And we are currently in the middle of the implementation phase in the pilot of the different 40 implementing sites of the 6 best practices, and hope to have enough and provide evidence of how evidence and outcomes at the end that we will end by November next year, hopefully. So thank you for being here, and we are delighted to be in this session. Thank you, Elena.
Thank you, Anna. As Anna said, when you see reports and so on, you see that it's been ongoing work for 2 years. What is not so visible is then, with the help of Lukianos, of course, Spain coordinating, Greece doing scientific coordination. For 1 year before we started, we worked very hard on methodology because we didn't want just to implement, transfer something as is. We wanted to see what worked and what didn't work. We wanted to study the systems and to have very robust implementation research methodology in place so that people could benefit, could inform scale up, and then, as you will hear from our younger members, implications for policy sustainability and what we hope to achieve. So I will pass, I think, the ball to Professor Leonis from my very own university in Crete to tell us a little bit more about the rather complex and difficult methodology to make robust, to generate evidence-informed practice. Professor Leonis, thank you for being with us.
Thank you very much, Dr. Petelos. I feel very privileged and apologies being remotely. Many thanks also to CIRCE project and to our coordinator allowing me and assigning me this important task. I'm started with just a little bit to begin our dialogue by focusing on current European challenges in the post-COVID-19 area. I think that, as you can see in the slides, the promotion of health longevity to reduce the burden of health and long-term facilities, the reduction of healthcare inequalities, and the strengthening of activities that support lifestyle changes are considered as very important. And to that extent now, primary care in Europe is able to contribute effectively to addressing these challenges. I think that is a key question. While there are a couple of successful initiatives, the visibility and the impact of transferring them more widely remain critical questions. In this context, the CIRCE Joint Action Project is dedicated to transferring best practices in primary care in Europe. Specifically, it aims to disseminate 6 best practices selected in 2018 across 40 implementation sites in 14 member states. In this slide, we presented the 7 work packets, which among others include the identification of methodologies for transferring practices and assessing needs, the transfer process and pilot implementation, the formative and summative evaluation, and also a sustainability. It also showcases the 6 best practices. Indeed, taken together, all of this experience, all of these practices could form a comprehensive, holistic, and person-centered European model that can address the healthcare challenges outlined above. And now that in this 4th slide, it's my pleasure illustrated the main conceptual framework, the 2 REACH framework, which guided our approach in transferring best practices across all implementation sites. Several key factors influencing successful transferring have been discussed with both the implementation sites, the best practice owners within Work Packet 5, in synergy with the leaders of Work Packet 6 and 7, and certainly with our coordinator of the project, Dr. Ana Maria Cariacho Perez, which I'd like in thanking warmly for contribution and also all her team. And coming now in the 5th slide, this slide illustrates the basic framework of methodology that we utilize in transferring the best practices. As you can see, it's describing steps, 8 stages, 8 phases, and personnel more formal implementation sites will train to follow this methodology during Work Packet 5. And we focus in more particularly on phase 2, where situation analysis and needs assessment, phase 3, planning based on local setting, and phase 4, training of a key staff. This slide is presenting the lessons learned from the transfer process across all implementation sites. We selected those with the greatest impacts at the national and European level, included among them the need of strong national and regional leadership, the importance of any early assessment of local needs, followed by adaptation of best practices to those needs. The necessity of detailed implementation guide included tools, templates in the local language. The active involvement of best practice owners, along with the availability of resources and local training. I think now I'm coming to pre-final slide that highlights workforce engagement. What we're learning in relation to this issue. I think that all of these 5 key issues could just summarize in the key statements that the involvement of healthcare planners at the national and the regional level is quite crucial. The engagement of local physicians, particularly general practitioners, is also considered as essential. Support for cultural change within organization is also valuable. And also, at the end, carefully attention to the details of best practices among the training for health planners and implementation staff is also necessary. And this last slide is focusing on Work Packet 3, where the evaluation methodology is illustrative. It is very, very important that mentioning that the 2 theoretical frameworks, Proctor et al. And RE-AIM, together with the consensus meetings involving the steering committee, best practice owners, and representatives from the implementation sites, led to 4 formative assessment indicators, currently in the final stage, and 3 summative indicators. I think that's a more illustrative figure regarding the methodology and the steps that we utilize in guiding the implementation sites and also supporting the whole package 6 incoming actors to transferring the best practices and implementing them into 40 implementation sites. Many thanks for your attention.
Thank you very much, Professor Leonis. And we know it sounds extremely complex, and perhaps this is not the best medium to see in detail what we have done, but the website for CIRCE-JA is active, and it has all of these stages, and we hope it will be of interest to the wider research and practice community. I would like to come now to Tony. We've heard already a lot, primary care, primary healthcare, lots of definition. We had Alma-Ata and Astana, and in this very own forum for the past decade, it's my third time here, and I think most of us have been here before. Every year we hear primary care. So I would like to revisit, start a little bit basic for the audience, for these concepts and for opportunities and challenges in the context of primary care. Thank you, Tony.
Can you hear me? Yes. Fantastic. First of all, I would like to say thank you very much, Elena. Thank you very much, Anna, and the CIRCE-JA action. I think this is a critical JA action. And as Anna said, as Elena said, I would like to start just setting the scene in a way that we are on the same page. So the same page is that I like very much the title of the session because you use a keyword, and the keyword is primary health care. And this is something that I would like to many of you, maybe you can get confused, but after my 3 minutes of intervention, I hope you are happy understanding what do we mean in this. So primary health care, so there are 3 words here, and it depends on how you bridge health and care. So it's a whole of the society approach to health, and this is so important, whole of society approach that includes multi-sectoral action, so that means different sectors together. At the same time, it brings together community empowerment, so we have the experience of COVID talking a lot about the community, so this is something that primary healthcare thinks and needs the community. And finally, integrated health services. Integrated health services that they should be in a very coordinated way with all care levels. And specifically, I would like to mention one that it's very relevant to you, Elena, is about the essential public health functions. And now it comes the critical word, and primary care. So I want to bring you what's primary care. So primary health care, primary care refers to the delivery of services close to the community. And we can define the community as close locally, close in a district, close wherever it is. You know? And Professor Leonis has already mentioned some of the characteristics of primary health care, and those are primary care is the first point of contact of the people close to them. The second one is that should be accessible in all ways, not just physically accessible in all ways, including the medical and treatments and diagnostics. Third, and this is very interesting, has to be continuous. And we've been, the WHO, when I used to work for the WHO till 3 weeks ago, we've been working with the Spanish Ministry of Health to try to evaluate the impact of the continuous relationship between the health professionals and the patients. So, and this is that continuity. It tells that people are much healthier and much satisfied about the services if there is this continuity of care. And then finally, I would like to mention that it's important that primary care is comprehensive. It's not just about medical care, it's about more than that. So these are the 2 definitions. I hope that I could finish here, but maybe I'm going to jump into, if you'd like, Elena, to jump into some of the challenges. And some of the challenges, seeing you here, I'm going to refer, but I'm not going to explain that WHO operational framework for primary health care. And my structure of these challenges will come from there, but I'm going to change the way I explain
Please.
them. I'm going to start that something that matters to many health systems, including in Austria. And this is the workforce shortages and the misdistribution of workforce in primary care level. And this is one of the key challenges we've got. Another one is that there is, and we are talking about innovation, there is insufficient, sometimes inexistent funding for innovation. And this is something that probably most of you are aware in your own context. Another thing that's relevant is about leadership and trust. Those two things are challenges for primary healthcare. One of the challenges is because the prestige, the reputation of primary care is still not spread all over the countries. Even some countries started the reforms just after the Alma Ata Declaration in 1978. And another thing that I'd like to mention here as a challenge, but at the same time could be an opportunity, is that data and information systems gaps. And gaps could be that digital health literacy, so there is a big gap with different people. We should be very careful not to leave some people behind using that, but at the same time, some countries are just testing new innovations in the health, in digital health, and maybe what they should do, something like CIRCE has done, so is trying to learn from the ones who's been successful. And then all that, we could reverse them, and I'm going to stop, and transform that in opportunities. And one of the opportunities is that, and I think Professor Maria Luisa is going to talk later on, is about the multidisciplinary approach, a multidisciplinary development and capacity building of the workforce at primary healthcare level. So I'm going to stop here to give the floor back to you.
Yeah, thank you. Thanks. And some of the things that Tony has just mentioned, workforce shortages, but also expertise capacity, not only in numbers we can discuss, we will be discussing later on. Before that, and thanks for touching on all the key components that we will be touching upon, I would like to pass the ball to Maria Luisa, because of course we want to know for a regional minister and for policymaker, what are the priorities and potential challenges you encounter and how value systems or social priorities come into play.
Okay, thank you very much. Indeed, first of all, let me say that it's a pleasure to me to stay here in this important forum, and also in this session dedicated to solidarity and quality in primary health. Okay, after hearing my colleague Tony, I really a little bit afraid, because I don't know if in my words I'm going to differentiate in a correct way, the difference between primary care and primary health care. So, Road, it's a pity, because I would like to hear your definition before that word that I'm going to say, but it doesn't matter. I'm sure that we are agree in the principal key, in the principal words that you use and that I'm going to use. Because in my opinion, indeed, like Tony had said, primary health care is the cornerstone of healthcare system. I agree with him, it's the first point of contact, it's the guarantor, of course, to continuity. And I can't believe really a better, I don't know how to say, I mean that without a strong healthcare system, or without a strong primary care, no health system can be no system can be truly fair and suitable. That's in my opinion. So primary care carries very profound and very enormous responsibility. Of course, because all the people that work in primary health have the entire responsibility to cover all the population, to cover the access and to cover the services. It's not depend the health system on where you live, on where your income, or where you work in social status. I think that primary care is a right, a very right for all, and they must deliver as close as people live. What regional governments do in this sense? Okay, we play a unique role because we know our communities. We know those people, who live in remote village, in rural areas, and we know also people who live in large city. So we need to know where are their specific needs, what are their demands, and then we have the possibility to match the really specific needs with our policy to grade and to continue improving what they need. They are our responsibility, because if not, we are not create a very health system where people are the center. It's my opinion, and after that I continue talking about what do we in a specific way, okay?
Thank you. Thank you very much. I think at this point to thank you both, and before we go a little bit further, maybe to say, since we have more than half full room to say, that you can submit questions and comments, and Marco is kindly moderating, but also that we have, of course, we're very happy to have Tony and Maria Luisa with us. Additionally to the people that are here from CIRCE-JA, to Elettra and to Professor Leonis and to Dr. Cariazzo and to Maximilian. There are many, many, many people that have worked on this, and we're talking hundreds of people. And we have with us a few of the local teams, so we have the Polish team and we have one of the Spanish teams, because Spanish is participating with multiple regions in this joint action. So I would very briefly like to have, if possible, if you would like to, from the floor, from the colleagues as well in Madrid, very briefly, a comment about what you encountered and how relevant or difficult you found the policies in implementing CIRCE-JA, and also, if possible, from the Polish teams, what was the main challenge that you encountered when trying to transfer from originator to implementer? So perhaps, Marco, first we go to Yolanda, Ana, and Juan from Madrid. Thank you.
Thank you. Good afternoon to everyone. My name is Juan. I'm representing here with Yolanda, Ana Luisa, FIVAP and CERMAS from Madrid, Spain. And we are implementers. We are implementing the best practice number 6, the Slovenian one. And to be honest, we are having an amazing experience, because this best practice is really, really aligned to our policies and our experience in health education. So we are having such a good experience in it. We are ending our action phase, and we are starting to collect all the data. We made several SWOTs and questionnaires and everything, and we are really, really excited to analyze and collect all that data. And some barriers we found is to put these kind of activities inside our daily practice with the health center. Our mitigation strategy for that was like doing a lot of planification in order to prevent all the planification, how to include these kind of things or some emergency that could appear in the dailies. Also the use of these technologies. We have a Pesalut tool to planificate and to accompany the professionals to do this kind of activity. And we increase our formation, our training sessions with the health professional, and also increase our meetings with each professional, like mentoring with individual professionals and with health centers. And in that way, we are like really happy to be here. Thanks for leaving us the floor to share our experience, and we are happy to answer any question you have. Thank you.
Thank you very, very much, Juan. So this represents transfer best practice within a particular setting. I do not know if our Portuguese colleagues are... Yes, very nice. So first, our Polish colleagues, Kasia and Kasia, thank you very much, briefly.
Hello, everyone. So when it comes to the Polish team, we think that one of the most challenging factors was the fact that we are implementing 4 of best practices, so number 3, 4, 5, and 6. So there was a lot of work from our side and our team. We think that very important factor, very important key, is that the healthcare professionals and providers know that the initiative that they are taking part of is very important and that it is worth taking a part in. We had a huge help from the BP owners. For example, just last week, our BP4 Best Practice 4 team was in Barcelona just to get more information about the practice and to share our implementation experiences. So we are very grateful for that. Thank you.
Thank you, Cassia, very, very much.
Thank you.
Perhaps very, very quickly, João from Portugal, to say that very important perhaps to mention that in this joint action, a very particular type of funding instrument. So if we didn't have a very strong relation, our health region of 7th Health Region of Crete, which is a government entity with the University of Crete, Agenas with local universities, Junta Andalusia with local experts, and the same for every country, this would not have been possible because you really need a combination of practice and policy and research. And I think we called it, when we had the meeting in Brussels, a side effect. The nicest side effect of the project, and probably you can see it from the energy, was that the people that normally would have never met or participated in research and so on in practice started to meet each other and started to forge relationships. So in terms of transforming healthcare and discussing European continuum of care, I think that's one of the nicest side effects we have. So please,
thank you, Elena.
João.
That was actually one of the things that I would identify in a very specific way. Portugal is both, it is a best practice owner and also an implementer. And I will focus on the implementation part of it. So just to give you a bit of context, since the beginning of the project, Portugal has its third government, a huge transition in the National Health Service. We are merging under the same board primary care and hospital care for with the local responsibility over the population, with a new funding model. And why is this important? Because these kind of projects give us a continuous line to motivate professionals, to give correct care to patients, even to create new services, because in 2 of our pilots, for example, is what we are doing. We are creating a new services based on primary care. That is something that for a health service like ours, primary care has always been almost the poor brother, with all the innovation and all the investment going to hospital care and to, for example, innovation in medicines. And primary care is at some point been left behind. And this is why all this tough methodology and project with a very defined goal is really, really important, to give this union around primary health care involving professionals, patients, and really, really, really important decision makers, policy, politics, and national institutions or regional institutions. Thank you.
Thank you very, very much, João. I think we keep this last word, the policy and politics also. So one aspect that was very interesting for everyone and to some extent neglected was, of course, the policy aspect. It's a very strange era in Europe and globally in terms of dynamics and in terms of, you heard about solidarity, but also we have a lot of individualism, and you heard a lot about communities and fostering relations to collaboration. So I would like to pass about to Maximilian, who did a lot of work in mapping some of these aspects, to tell us a little bit more about this context. Thank you.
Yeah, so one reason why I appreciate this transaction so much is that some of the big policy challenges of our time can be tackled by primary care in general and the best practices that we used in this transaction in particular. Tony talked about health workforce shortages, but there's also health misinformation, which is said by the WHO to be one of the big problems of our time, and also scarce resources, and the losing solidarity that we experience, and why this conference is called Regaining Solidarity. And I think that if we look at misinformation, for example, one key element to tackle this is trust. And we know from the Paris study done by the OECD that people and patients tend to trust health professionals that they meet more than the system in general. And their primary care comes in, and if you have a good primary care system, then you have the continuity, the personal continuity, and so that can help elevate trust. And what is also increasing trust in primary care is if you have time for the patients and if there's continuity. And for example, the best practice, the personalized action plans from Andalusia, they try the health professionals sit together with the patients and talk about like a goal-oriented primary care, like what is really important to the patients, and that takes some time, but then the trust is increasing and the patients feel seen. And this is also tackling the resource issue. You discuss resources, but by then you can decide like what is necessary, what together with the patient, what do we do, what don't we need to do. And also, for example, if we talk about the, I think this is just one of the many policy challenges that the joint action has helped tackle.
Thank you very, very much, Maximilian. And in terms of transforming healthcare, of course, sometimes you implement a best practice and it's reaching the majority of the population, most people, but nevertheless there are many people that find themselves without access and or accessibility, encompassing different modalities, including affordability and so on. And we have different phases for that. We call them vulnerable. Sometimes we say disproportionately disadvantaged, or we say minority populations, or even underserved. So I would like to come back to Tony on this and say where are we in that in terms of we're introducing innovation in the system, not only technological. Does it actually reach the people it's supposed to? Because the ones that need it more usually are the ones that have limited access to it. Yeah.
See, yep. Okay, yeah. And thank you, Elena, for the question. And one of the things, I'm going to give you 3-4 points on that. And one of the things is equity should be embedded in any innovation from the very start. It shouldn't be an afterthought. Oh, we haven't included equity in what we've been doing. And for that, I can give you examples. If you want to develop something for people in remote areas and isolated areas, or people with maybe that they are underserved in some ways, you have to keep in mind that their needs. So for that, it's important that any innovation that you try to introduce in primary healthcare has this into account. One thing that's, I'm going to give an example, and I see João here from Portugal, in Alentejo. Is one of the regions in Portugal, in the south, I think. And one initiative was to, there were people in rural areas, in very remote areas, with very low digital health literacy. And one of the things they did is co-created a solution between the local community and the innovators in primary healthcare for them to be able to have access to the services. So this is a very, not a high-tech solution that was implemented in Alentejo, but it's a good example. Another thing that's important when we try to think about innovation and mechanisms of innovation is that we should take into account what are the financial mechanisms. So sometimes when you try to recognize the efforts that people or groups are doing towards some most vulnerable population, this is not compensated economically. So, and this is something that it happens in many countries. There is an example that it was used, if I remember well, in Estonia. Yeah, imagine an e-consultation. In some countries, e-consultations are not paid. You know, and imagine if you try to reach the most vulnerable and the people with lower access to the services, if the providers are not paid. So this is an impact, direct impact, and the demotivation of the providers to have access to the people that they need most. This is another example, a very concrete example, that Estonia introduced this mechanism to recognize that. Another thing when we discuss about innovation is sometimes there are donors, could be the European Commission developing some innovative project somewhere, it could be the World Bank, could be many other organizations. And they start doing some projects there, but sometimes they are not aligned with the national or subnational strategies, and they clash in terms of, okay, there is an innovation, sometimes there are duplications, and the WHO in headquarters, they develop a tool that it's called Primary Healthcare Global Health Initiative tool, just to know who is doing what and in terms of innovation and where. So this helps in many countries to do that. Another thing that maybe it's important to tell is about, it's not just trying to carry out pilots wherever you can. I think we should introduce a new concept, that is the implementation of science. So we have to, you can do a pilot, but monitor that and see if this pilot is able to be transferred or to scale up. This is another concept that to reach, and this is something that's important. Normally in these pilots, something is missing, is the equity indicators or some equity components. So this is something that could be taken into account. And finally, I would like to mention something important, that it comes from the bottom up, is look at the local champions that you've got in each place. I can share with you an example of the region in South Lapland, in the region Västerbotten in Sweden, that this is an area that is almost as Austria, and it's got just 150,000 people there living, so the dispersion of the people is huge. And thanks to champions and innovators there, they've managed to facilitate the access with telemedicine services, with digital solutions to those people in very, very isolated circumstances. But that was done thanks to some champions, leaders at local level, that they convinced politicians at another level to encourage and to innovate and to recognize innovation at those levels. So that's my thoughts about the mechanisms, I could say.
Thank you very much. 2-3 brief comments. It's very difficult without the slides to see how all of these aspects were factored into the methodology for CIRCE. But I assure you that the most difficult part was defining formative and summative assessment and actually mapping the local needs and the populations, because we had to develop the appropriate indicators. And this was a painstaking process because we had to break down the best practices, see why they worked in their context, see what may or may not work in the new context, and then find mechanisms to assess whether the best practice was being transferred as it should, which was one module of success, and then whether it was giving us a desired outcome, and whether it was still a best practice in the new setting, and that's an entirely different proposition. And I think it sounds very boring to talk about indicators and so on, but iterative or continuous or iterative evaluation is an inherent component for implementation science and research. So thank you very much. We went a little bit off, but then we come back to Maria Luisa, and then of course regional priorities again, from the perspective of the policymaker.
Yeah, okay, thank you, Elena.
Pleasure.
Okay, as everybody knows, I have a politician responsibility in Andalusia. As you know, Andalusia is a region located at the south of Spain, and we are more than 8 million of people over there. I'm proud to say that we employed a large amount of our budget to primary care, because we are convinced that this investment in healthcare and in social care is great for cohesion. I think it's very important to say that. I think that strengthening primary care carry out three important things. I think that reducing hospitalization, improving health literacy, and building resilience in our system. In Andalusia, our network of primary care center extends across all territory. As I mentioned before, these centers are in the little areas, little village, and also in great areas, in great city. These centers are staffed by a multidisciplinary teams. I mean, there is family doctor, not only physician, also pediatric, of course, nurses, dentists, psychologists, of course, also social worker. And the important thing is that they work together in order to manage not only disease, but also, of course, prevention and promotion health. That is something that I want to remark, because I believe a lot in health promotion and prevention. Importantly, our approach also connects with social services. We know I suppose that you are agree with me that social condition shape the health. Shape the health by those conditions that means where people live, where people born, where are the social and in general, I mean that we need to connect those big services, health and social, and this is permit us to create and to manage better the older people, the adult older people, also with a complexity of chronic disease, and also to attend those vulnerable population, this social vulnerable population. Integrated, this model is very important, but also don't forget to give also power, empowerment citizens. I think that we need also, someone have mentioned that people need to get to manage their disease. So we need to give them tools to manage their disease and to make decisions about which is the treatment. So it's nice to hear people here in the former presentation, in the former event, people from association of patient association that ask to us because they want to participate. They want to make their opinion, to put their opinion in how it managed with doctor, with nursing, or the professional too. So I think this is very important, empower the citizen. So I would like to also say something that is as a word that I love it. This word is trust. I believe in trust. And when I say trust, I want to say trust between patient and doctor, between citizen and their healthcare institution. I think that trust is the key to improve and to maintain what we are talking about, primary care. Okay, I'm convinced that if we are able to sharing all our experience across region, across country, we are we are greater manage everything that we are talking about, but all together we get it. Okay, thank you.
Thank you very much. So, Maria Luisa, you opened many different things. Some have to do with co-creation and deliberation, not just passive consultation, and we have new tools for that, although we don't see them yet happening, not only patients, but healthy citizens, potentially patients one day, or carers, and so on. And we also have, of course, issues of implementation, acceptance of what we implement in very highly varied settings. So Greece is small, Italy is not a massive country, but we see very different types of variation. And also we have centralized decision making versus regional or even setting level decision making. So to that effect, I think I would like to hear from Elettra, because Italy is, in the joint action, has one of the most challenging aspects. It had to transfer, I think it's 13 to 13 different settings. And when I say different settings, I don't only mean regionally, I mean also highly heterogeneous, different funding mechanisms, different protocols for providing care and so on. So please, Elettra, if briefly.
Yeah, exactly. I would like to start from this point that we are going to implement and transfer. We are actually implementing and transferring in 13 different contexts. And the organization of these 13 affiliated entities is actually very different. And so adaptation, the transferring process and the adaptation is very context dependent. And furthermore, this joint action is a very practical joint action. So that means that many places in which we are implementing the best practices may have never joined a European project. And so also the difficulties that they have in the familiarity also with all the processes and the reporting, the monitoring that is behind the joint action. So all those organizational issues are really not an issue, but still they are a challenge. And then going a little bit broadly, as Elena said, we, as Italy, we have a national healthcare system, but regions has their own autonomy, and so that means that the organization is different and we have to take care about it. Then another aspect which is really making its role in the joint action is also the context in which we are now, because by now in Italy we are facing two major, one major reform of primary healthcare, and another thing which is really important is the National Recovery and Resilience Plan reform. So we have these two major goals that we have to reach that goes together with the joint action. And sometimes setting the priority on what should be done first is not easy. And many times the people that are working on the joint action are actually also working on the National Recovery and Resilience Plan and on the development of the primary healthcare reform. Exactly. So it's kind of difficult to bring everything together. Fortunately, I would say that the joint action has this as similar goal than the other reform, and that really helps in taking everything ahead. Then I would not repeat again because Tony has already said, but anyway, also we also face shortages in healthcare workforce, and also the aging of the healthcare workforce, which brings with it also a sort of resistance to change. So implementation is kind of difficult in many places. Also, another problem that we face is the fragmented and sometimes not even existent IT systems, and IT systems are really important for monitoring and evaluation. So, and we are working on it as well, also through the primary healthcare reform at a national level. So those are, let's say, some main challenges that we have to face while implementing the joint action. But hopefully we are doing everything, and hopefully we will find a way to go till the end.
Thank you very much, Elettra. In the interest of time, because we started a little bit late and we're a little bit over time, Marco, do we have any pressing one? Any questions or comments?
Yes, thanks, Elena. Well, we got some energy online, actually, but among the topics raised, the trendy one was trust. Yes. So I will just bring up two of the questions. Yes. how can regional authorities can build stronger trust with communities when introducing new primary healthcare models, and if the panelists see challenges regarding the importance of trust versus digital solutions in primary healthcare, and how to build trust also towards the digital solution.
Thank you, and from what I see, there is a question I can easily do. Do we have a view of collecting and using data? We're already doing it, painstakingly, but we're already doing it, and in all the participating sites. So I don't know when we will analyze it, but we are analyzing it as we go along. I mean, we are doing it. On the trust, which I think Maria Luisa brought up, and it's a very important topic because we have seen emphasis, I think in COVID, the most basic indicator was if people had built trust before COVID, then they trusted the government and the decisions, and local government and primary care is the best place to build it. And then perhaps this is for another session in terms of how can primary care transform social contract to some extent, and even trust in institutions. So I would like you to think about that for your final statements if we have a final round. But if possible, I would like us to continue, unless you want very briefly to make Maria Luisa. I select Maria Luisa because you mentioned the trust. So.
Yeah, but
please.
About trust.
Please. It's okay.
I heard about that it's very difficult to put in parallel trust and digital transformation, I think. What did you say, Marco? Did you say something about that? Trust and digital transformation?
It's here.
I can read it, sorry.
How can regional authorities build stronger trust with communities when introducing new primary healthcare models?
Perhaps I'm going to say something about that in the next question. So if you want, I will respond to
Please,
that.
incorporate it in the...
Incorporate it.
Let's continue.
Of course. Okay. In this next section, perhaps I respond to this question, because
but we can start. We don't have to have any particular. Please start
I start?
Absolutely,
Okay,
because we want to discuss this and also workforce shortage and so on. Please.
Okay, thank you. So in the next question, I would like to put a very point about the problem that all healthcare systems have and face that is the reality that the shortage of healthcare professionals is a reality. And particularly, I'm sure that this is very relevant in primary healthcare. Why that? In my opinion, there is three reasons of that. First, because demand is rising. Second, because complexity is increasing. And also because citizen expectation is stronger than ever. That's my opinion about that. In my region, in Andalusia, what are we doing? And we have several innovative initiatives because we are convinced that the solution lies in a combined approaches. So strengthening multidisciplinary teams, embracing digital tools and complement that digital tool complement to human care together, as I said before, empowering citizens and fostering health promotion. And primary care, what are we doing? We try to diversify responsibility to better match supply with demand. Incorporating additional profile to those that already exist. For instance, I want to mention consulta de acogida. What's that? Consulta de acogida is reception consultation that is worked by nurses. Nurses today in Andalusia manage more than 50% of all of demand, not severe but urgent, and they manage the visits. It implements a lot of free time to doctor and cover in a quickly manner, in a quickly way, the day-to-day in the primary health center. Regarding also digital transformation that we mentioned, we have a massive use of corporate information. we have a common electronic health record that is shared at all levels of care. When I talk about digital deformation and to put technology at the service of professional and patient too, I meant to mention that about the question. Digital technology, we need to think about something to complement care, human care, not supply them. So we need I want to say again, the trust between doctor and citizen, between patient and doctor, between responsibility of health institution. Because only if you use technology, digital transformation, to something complementary to human care, I think it's possible to get together all things, because they are tools to implement the healthcare in patient and in professional. That's I want to put together, because it's very important to mention. The technology is here, digital transformation is here. It's come and never go away. So I want to speak about it in a very positive way, that only serves that a complement. It's like, I don't know, in my former work, it's like my microscope. My microscope is my complementary tool, but not replace my knowledge, okay? So I try to explain with this example what we think about that. Thank you very much.
Thank you very much. Tony, I'll come back to you, but very, very, very briefly in the interest of time, because you mentioned workforce and you also mentioned digital transformation and other megatrends. So could you care to elaborate a little bit in terms of how this transform our priorities?
Elaborate on those, or elaborate on new ones?
New ones.
Well,
but briefly, if possible, very briefly.
Very fast. Well, I'm not going to list all the mega trends that you have in mind. I'm going to give you I'm not going to make publicity. I'm not one of the authors, but there is a paper recently published about 3 weeks ago by The Lancet, by Luke Allen, is about primary healthcare in the 2030, and they explain lots of the issues we are discussing here. Yes. How do these authors see what's going to be in 2030 and beyond that? So I recommend that paper. Sometimes it's got an ambivalent. It can be positive, and sometimes it's a little bit negative. And I'm an optimistic person. And one of the things I want to, I see primary health care as a platform that connects. I should connect, you know? And this means it impacts to the workforce. But one of the things that we haven't mentioned very much, that the connection should be between public health, social care, we haven't talked about that. And another thing, because we should understand primary health care as a well-being asset that we've got. Another thing, we see more often mental health issues, some cultural and spiritual diversity in our communities, in our societies. Absolutely. This is another challenge that we've got.
Behavioral aspects, very important.
And digital, you could say digital exclusion, but I would say digital inclusion is what we need for the future of primary health care. That means that we need workforce constantly being prepared to give response to these cultural and even values that change the society. So we cannot respond in primary health care in the same way we did it 40 years ago. The values of the young people, the values of the societies are changing. So this is something is our big challenge. But there is many opportunities for innovation. Another thing is opportunities that we've got. You could work proactively, and nowadays you can use artificial intelligence to use some predictive models of how are the workforce needs according to the prevalence of conditions. You could extend that to how are the prevalence in the next 10 years. You can even train and form the different professionals of primary health care depending on the simulation exercises. This is possible, and some places they're already doing it. So this is not just a dream, this is a fact. So, and then one thing I want to end with something that you said. We have to learn how to work in a way that's interdisciplinary. So it's not just primary health care, the family doctor, the nurse, and the social worker. It's more than that. The new roles, there'll be some hybrid roles. So a few weeks ago, I went to my surgery. My surgery is the GP practice in the UK, and I had an issue with the app, and they've got an IT technician specific to attend the people, the elderly people like me, you know, to support in something that they don't know how to do. And this is at primary health care level. So this is something that there is future and opportunities for innovation.
Thank you. I was hoping you would not mention AI because we would not, it's a very intense discussion. And we are kind of on time, but before we go to what our vision is, which is the last part of this, what our vision is going forward, to say that some of these things are already happening. The point of CIRCE-JA is to develop also and deliver methodology so that these things can be scaled up quickly and effectively and efficiently. But there are two questions from the floor. I think there is a lady there, and there is a gentleman just after. Thank you. If you could very briefly tell us your name and where you're from, because it contextualizes the question. Thank you.
Thank you very much. My name is Aneta. I'm representing the IFRC, International Federation of Red Cross and Red Crescent Societies. I'm based in the regional office for Europe in Budapest. I have one question to the speakers and panelists. My question is how they see the role of the civil society organization or international organization in strengthening the primary health care. Maybe just one comment in this regard is that I think that civil society or the community-based organizations have a crucial and vital role in strengthening the primary health care because they are like some kind of linkage between the community and the primary health care services. And there are a lot of models among the National Society Red Cross societies in the Europe that are implementing a very good cost-effective and
cost-effective is a big discussion whether it's cost-effective measured.
And activities. And you mentioned the models, for example, to help and support the older people. We have this home care model that is person-centered model that is direct linkage between the community, the older people, and the social and healthcare system. And we have also seen that during the COVID-19, this promotion, prevention, and direct trust and being in the communities is very important, and it's we see the results there. So my question is how they see on the role.
I will answer because I'm involved in that, and also I think you will hear a little bit more about what we plan to do with the observatory and so on. There is a policy forum within CIRCE, and there is a stakeholder mapping. So the last year, which is starting in a few months, let's say the final year, is exactly reaching out, not only community outreach, but reaching out civil society, more broadly patient societies, other models and how they can loop in. And you will hear in a couple of minutes, let us say a little bit more about the observatory. But thanks for reaching out. And also please directly reach out because we are about to expand the stakeholder mapping. Thank you.
Thank you very much. My name is Tomislav Šuljević-Salomon. I'm Austrian. And thank you just 1 minute. It's less a comment I have, it's more an invitation. But I felt very invited from the subtitle of your workshop and also in the different speeches, a lot of keywords addressing what we are doing in our project. I'm manager of one of the 20 flagship projects of HDEA. The name of the project is EU Promens, and we are very responsible for the field of mental health, and this is also an important part of what we are discussing here. And we are we're working in the same field with different instruments and different methodology. We are offering, for example, 900 expert exchange trips all over Europe, or 3,500 training places in 30 different countries in Europe. And I only want to say, and it would be so nice, because we are discussing in the HDEA meeting so many times about possible synergies with other projects. And so it would be really nice to have a discussion about your experience, our experience. We are almost at the end of the second year, and we will end 2026. So if there is a possibility to have such a discussion.
Yes, absolutely. It's the same for us. We're towards the end of 2026, and our last year is more or less dedicated to clustering. We have put it explicitly. Anna will tell you we had a lot of discussions from inception, so I'm pretty sure we can ask kindly Lukianos and Maria Canelis to facilitate, so we have a formal exchange. And thank you very much for reaching out. Thank you. I cannot take another question. I'm sorry, because we're completely off time, but please send it to us. But I need to go to Elettra and also Maximilian, because I would like them to give us an overview of where we go now in terms of sustainability, which is always a pain, as you know, in projects. The project finishes and what happens afterwards, and what the vision is of everybody for continuing this. So I think first Maximilian for the setting.
I just have a quick comment.
Please.
I'm hoping to have another joint action after this one for two reasons. First, that I think every health reform is kind of a joint action in its own, because always, for example, now we look at reforming patient navigation in Austria, and what we do first is look at other countries in Europe, how they are doing it, and try to analyze it and then implement it. And the second reason is that I know you react allergically to AI, but all those six best practices, all those 6 best practices were developed before the AI wave took off. And I think if we would create different best practices now, they would look very differently. And I would be curious to see how this would work out.
Thank you. Not reacting allergically, I'm the chair for AI in RWE, as you know. I just think people sometimes overestimate or underestimate the complexity, overestimate the potential. It's very complex, and absolutely we can discuss, and also we can have with HDEA more discussions on what can be funded. But thank you very much. And last but certainly not least, Elettra, if you can give us an overview. Elettra will speak about an observatory, not the observatory you all know, in relation also to Gerstein and the publication. So please, Elettra.
Yeah, so as Elena briefly said, as Agenas, we are, the leader of Work Packet 4, which is about sustainability. And one of the objectives of the joint action is to sustain what we have done until now and what we will do next year, also beyond the joint action. And also another element would be also the scalability to broader part of healthcare systems. By now, all that we have done concerning sustainability is to analyze the factors that can, in the short term and also in the long term, sustain all the practices and in the implementation. And the ongoing work that we are doing now is has two let's say, main lines of activity. One is more contextualized to the implementers that are working right now, which is the creation of sustainability plans in order to make them more aware of what they have to do from the end of the joint action beyond. But the other element is the observatory, the creation of European Primary Healthcare Observatory. But going a little bit before explaining more about the observatory, I would like just to underline what we focused on the last years. And we know that sustainability is a dynamic interaction of different factors. And some of the main factors that we found, that, I mean, it's not just us, because they are actually very well known, but some of the factors that we underlined that compose this dynamic process that is called sustainability are for sure the integration into policy and into the institutional organization of the practices that we are implementing. Another element is for sure the adaptability of because you know a practice cannot be just translated as it is from a context to another. So we have to do a lot of work of adaptation. Also, another element which is fundamental is the economic sustainability. So the funds to run, I mean, during the joint action is quite easy on this part because the joint action has funds on its own, but after the joint action we have to think about how do we implement more and again the practice. Should we reallocate funding? Should we create a budget of its own? Should we explore even new and I mean innovative ways of funding? Then another element which is pivotal in the implementation is, and the sustainability, is human resources. And a very important element is to train them and to make them understand why the implementation of a practice is important, to make them understand the benefit, and thus also the importance of IT systems, because in this way we can monitor and evaluate and make them, not just the healthcare professional, understand why the implementation is important, but also the higher level of stakeholders, which allow us to continue the implementation. From this lesson learned, what we want to do is to then develop and start with the kickstart at the very end of the joint action, the observatory, European Observatory on Primary Healthcare, and it aims to reinforce the national, regional, and local level on primary health care, and it wants also to give, let's say, a context in which everyone can share knowledge and share experience. We want it to be very active and not just a page on the internet. So, and we want to open, for sure, the observatory also beyond the one participating right now in the joint action. And we are just at the beginning of creating the observatory. We are just right now setting the methodological foundation, which means that we are also reflecting more on what does it mean sustainability. So to analyze which are the challenging elements, to manage constraints, and then finally to work toward the same goal. After this, let's say, first part, which is more methodological, but which is fundamental to make something that works, what we want to do is to co-design, and so also to invite more anyone that can give us, that can contribute to it, and then finally just to disseminate and to make this observatory work and be as much as useful for everybody. So, and that's, I mean, we are open to also to receive ideas and to receive also a sort of first call to be part of it from all of you.
We are well over time. Thank you very much, Elettra. So I would like to ask Dr. Gatzoulis and Professor Yanis for a 30-second final statement. I am sorry, but we were well over time. So first, I will pass the ball to Professor Yanis. In the interest of time, if you can have a final statement on the basis of what we heard, but a very, very brief one, maybe one sentence. Thank you.
Myself?
Yes.
Okay, thank you very much. I think in simple words, the challenges to, based on all the experience we get from CIRCE, is to invest to workforce. It's very important to invest on the future leaders, either at the local level, regional or national level. Of course, that is the task of governments and the health planners. The second, teamwork still is missing. It is very, very important to a little bit investing and enhancing teamwork through undergraduate training. And that is the integration of the field of education with healthcare is very important. This is a task for universities. And the last one is important to invest on integration of public health into primary care,
exactly.
Jointly with the stakeholders engagement. I think that it is very important in summarize the experience gained in Europe, and that, of course, is the task of HADEA and European Union. Thank you very much for kindly inviting me.
Thank you very, very much, and also for touching upon what's critical, teamwork, including interdisciplinary teamwork. Lukianos, there are already a couple of asks for a new joint action and for more work on primary care, including from Maximilian. So kindly, your last key message, and also you may have heard the intervention about another of the flagship projects. So if we can have more from that briefly, whether we can cluster projects and what your thoughts are for the future from this action onwards.
Well, my immediate thoughts actually would like to build upon what Elettra was explaining about the future sustainability plans. For me, it is very, very important that the health authorities follow up with not only elaborating but implementing the sustainability plans that the project is developing, the joint action is developing, and making sure that they utilize EU funding currently available for whatever reason, whether it is facilities, human resources, or organizational aspects. And right now, the opportunity lies still with the current cohesion policy fund. But look further forward, and you can see what the Commission has proposed for the next multi-annual financial framework for 2028-2034, the national and regional partnership plans. These offer a very sizable pool of funding to member states to invest in all sectors, including in health. So those who want to do large-scale deployment of action plans to strengthen primary care, look into these opportunities. Thank you.
Thank you very much. I think we are making an effort, those of us that are closer, to make people more aware across jurisdictions. And now I would kindly ask you, starting with Tony, very briefly also for one brief statement, one key message from all we have heard, which is, I think, more expanded than we have originally discussed, but worth the time. So please.
Yes, thank you very much. Oh, sorry. Thank you. My short statement is that primary healthcare needs innovation, but needs innovation that gives response to the people's needs. And then innovation needs to be evaluated, and then this is the only way you can close the loop, the cycle of innovation. So you have to monitor, you have to evaluate, you have to innovate, you have to rethink, because this is a critical moment for primary healthcare. We have to rethink together. And when we say together, is cross-sectoral, as I said at the very beginning. Now, we have to think together, but you have to generate evidence for the policymakers and I'm not looking anybody, so that they invest more in primary health care, because we know that there is still infra-funded, not in yours, you are a good example, yeah? But this is something that it would be my last
Thank you
remark.
very much, Tony, and now you pass on to the good example, if possible, the microphone. Thank you.
Thank you very much. Okay,
sorry to put you in a corner, but yes.
Okay, thanks. In a few words, I have another final statement, but I rewrite a little bit after hearing some important thing that I heard here before, during this session. And in a very close way that Tony have said, I remark that our regions in the forefront for innovation in primary healthcare. Regions, okay? It is, this primary healthcare is a protective umbrella of our social contract. This is important to say it. And it is built, like we say, on trust, and is strengthened by a systematic implementation research that turns innovation into a sustainable transformation. Of course, we need to improve. I am a politician now in Andalusia, and I'm sure that we need to improve. I said before that I was proud about the amount of our budget in primary healthcare, but it's not enough. Never is enough, because we are combined. That is the forefront, is the cornerstone that gives guarantee to everybody. But it's important to stay here, hearing you, and learning a lot about we think and we learn. Thank you very much.
Thank you very much. Anna, do you want to make a final statement? You are still the coordinator, even if not in the podium, no? Okay, we pass the ball to Elettra.
Okay, yeah, going back to sustainability, as I said, it is a dynamic and complex process, and especially bearing in mind that we are in an extraordinary, we are part, all of us, of this extraordinary entity that is European Union, which brings together differences. We should all work together to make all the better ideas, all the better practice around Europe transferable and sustainable over time. That is why sustainability also is important to me.
Thank you very, very much. Last but certainly not least, Maximilian.
Yeah, coming back to the topic of the conference, I think that primary care can play a key role in strengthening solidarity because it is person-centered, it is less resource-intensive, and it can be equally distributed over the country. And yeah, this is my key message.
Thank you very much. We had planned for me to do a summation, but I don't think one is needed because you probably have seen that there's cohesive exchange, including with the policymakers and with the third sector. So please stay engaged with us. I think the Polish team is leading dissemination and communication. We're very happy to have it with them. Please reach out. I know there was another question. We'll be happy to answer it offline. And of course, we'll be happy to discuss clustering with other projects and involving civil society and patient organizations. And with that, I release you and thank you for bearing with us for an extra 15 minutes. Thank you.